Please do.
Okay. Hello, Dr. Depti. I'm candidate one.
Yeah, candidate one. Can you start? This patient presented with trauma. You have a lateral and an AP radiograph. You can take both. When I will like you to take the odontide view, I will tell you. Okay.
Okay. I'm presented with the lateral radiograph of the cervical spine. I can see a lucent line seen at the junction between the C2 vertebral body and posterior elements, and there is disruption of the posterior longitudinal line, and there is mild soft tissue swelling seen anterior to C2 vertebra. There is preserved atlantoaxial distance with no evidence of atlantoaxial dislocation or subluxation. I can't see any other fractures within the anterior or posterior vertebral elements. This is likely representing hangman fracture, reflecting extension type of injury, and this is unstable type of injury. I'd like to urgently pick up the phone and urgently alert the referring physician about the finding and recommend the spine MRI to assess the spinal cord injury, and I refer patient for orthopedic team and neurology.
Okay, you don't want any orthogonal view?
Yeah, of course, I'd like to see the other views. Okay, on the anterior AB view, there is no evidence of pneumothorax or other fractures within the ribs or the medial part, the visualized part of the clavicle. The dense process appears intact. There is no fracture at the base of the dens. The atlantoaxial distance, the joint is almost symmetrical bilateral. It's slightly asymmetrical due to rotation. However, I can't say that there is a dislocation. And also on the if there is any other view, yeah, and on the odontoid view, the joint alignment between the axis and the atlas is stable, and it's almost symmetrical, so there is no evidence of atlantoaxial displacement. So I'll refer patient for MRI.
You wanted what after MRI? Okay.
And CT, if the patient is planned for pre-operation. On this, okay.
You want what? You want a CT or you want an MRI?
MRI for cord injury, to assess cord injury. And if the patient is planned to do operation, if the team wants CT, I will request CT scan for pre-op.
You won't recommend a CT?
No, I will not, unless they will do operation and they request it. Okay. Shall I request the remote control?
Yes, please.
Okay.
I'm present. You want? Okay, fine. It is a gradient echo. You can carry on.
This is axial MRI images, gradient echo of the same patient. I'm looking at, I'll start from the up sections. I'm looking for any evidence of displacement or injury within the spinal cord. And also for any blooming artifact within the spinal canal that suggests internal hemorrhage, intra or extradural. I can't see any areas of blooming artifact. There is bulge seen at the posterior aspect of C2 vertebral body, intending the CSF space. However, it is not abutting the cord. So I'd like to see the T2 sequence to better assess the cord signal if there is any associated myelopathy.
No, leave the mouse. Which T2 do you want? Axial T2 or a sagittal T2?
Sagittal, it's better.
Here you go.
Okay. In this sagittal T2 images, there is no hyper-intense signal within the spinal cord to suggest myelopathy. And there is mild bulge. However, it's just indenting the sac.
Do you want to see any other sequence?
The stair also can confirm any, if there is, okay. On the stair images, there is no spinal cord injury or abnormal signal.
Did it add anything to your findings of from the radiograph?
I'm trying to assess the ligaments at that region. Okay. I can't see any. There is disruption of the alar ligament and slight abnormal signal within the alar ligament. However, there is no epidural hematoma or extradural hematomas, okay. And there is mild swelling. I'll also check the rest of the sequences and the axial images to confirm that there is no injury within the cord. Also, the spinal canals, there is no compression on the spinal roots at the same level. So I'll alert the referring physician about the finding. There is a annular tear also at the same level, and I refer patient for orthopedic team for fixation for impossible need for surgery.
So finally, your diagnosis is for the case?
Hangman fracture with annular tear and ligamentous disruption. However, no cord injury or extradural hematomas. And the vertebral body is intact, the vertebral artery.
Sure. I will give you another case. So here you go. This is a immunocompromised patient presented with bleeding, rectal bleeding. You need to ask for control again.
Yeah. I'm presented with axial CT images of the abdomen, contrasted study in the portovenous phase. Trying to scroll. Okay. In a patient who's immunocompromised and presented with GI bleeding. There is, I think there is filling defect in the pulmonary artery, the left lower pulmonary artery. I'll urgently alert the referring physician about this finding, and I continue scanning the study. There is filling defect also within the IVC. There is large soft tissue mass lesion seen in the renal/suprarenal area. I'd like to, when I finish the study, to see the coronal images to localize this. However, there is another
lesion. Don't panic. See the case once. Completely see the case once. Don't panic.
Okay.
See scroll through. Yeah. See through the case completely from top to the bottom.
Yeah. There is.
Don't talk. See the case. Go down. Completely go down. Yeah. Now again you go up and start speaking.
Okay. There is multiple masses seen involving both kidneys and the liver, as well as the pancreas, also the left liver lobe, we said, and also the right supraadrenal region. The mass is appear aggressive. The lesion in the left kidney is showing extension into the left renal vein.
Yes.
And also the lesion within the right supra adrenal area is compressing and displacing the IVC. the liver lesion is also involving most of the left liver lobe. There is also evidence of, there is no evidence of portal vein thrombosis.
So, okay, fine. There are multiple masses in the abdomen. Okay, fine. There are multiple masses in the abdomen.
And also in the peritoneal cavity.
What is your diagnosis?
In a patient who's immunocompromised, I'll be thinking about lymphoma.
Okay.
Also,
what lymphoma? Which kind of lymphoma? Primary lymphoma, secondary lymphoma?
Secondary lymphoma, lymphoproliferative disease.
Yes.
Could occur in a patient who's immunocompromised. That is involving multiple organs. And there is also multiple filling defects within the IVC and within the with paradoxical PE in the left lower lobe. So I'll urgently alert the referring physician about the finding. And there is, I think, possible filling defect also within the atrium, within the right atrium. So I'll urgently alert the referring physician about the presence of PE and recommend starting of anticoagulation. And I'll refer patient for lymphoma MDT or oncology MDT and recommend biopsy, further chest imaging with the PE protocol for to see the extent of the PE and the presence of cardiopulmonary compromise. And also I'll recommend biopsy and we said that patient present with bleeding, so I'm trying to see if there is any colonic masses. There is a few enlarged lymph nodes I can see as well.
Go to the pelvis. Go to the pelvis.
Yeah.
There's something in the pelvis.
Yeah, I saw there was a uterine. Yeah, I think this is a uterine.
Are you sure it is uterine?
No, sorry, this is a male patient. So there is a large pelvic mass in the prostate gland, I think, and
yes.
It is indenting the urinary bladder and possibly invading the urinary bladder. As I can't see any clear fatty plane. However, this needs the pelvis MRI for better staging and
any other differential you want to give except for lymphoma?
It could represent metastasis from unknown primary, multiple metastasis. That
okay.
it could be the primary renal lesion, and these are all metastases.
Very good. And apart from that, you want to see something in the current imaging? What you have seen
the bone,
already?
Of course, I'll review the bone for the presence of bone metastasis and the lung window for any lung lesion. And there is mild left pleural effusion.
Yeah. Okay, fine. We'll go to next case. Leave the mouse, please.
Okay.
Can you see my screen still?
Yeah.
A 13-year-old boy, large bone swelling.
Okay.
Can you see that case?
Yeah, I can see it, but I can't. Yeah.
Yeah.
Okay.
So here you
I'm presented with the lateral right leg radiograph of a 13-year-old boy who presented with leg swelling. This skeletally immature patient. I can see expensile lytic lesion involving the anterior aspect of the mid-right tibia with internal septations and surrounded sclerotic margin. And there is no evidence of soft tissue extension, no evidence of pathological fracture, and there is no periosteal reaction that's identified apart from the surrounding sclerosis. There is a narrow zone of transition and no internal chondroid matrix. I am suspecting adamantioma which is typical to be in this location. And I'd like to see the other views and the previous images if the patient is known to have this disease. Yeah, on the frontal view, there is sclerosis and expansion at the same region, and no clear reosteoreaction or associated pathological fracture. I'd alert the referring physician about the finding, compare with the previous images, and recommend if the patient is not known MRI for better characterization. And also I refer patient for I think adamantonoma is a benign lesion that's managed conservatively unless there is.
Are you sure that it is an adamantonoma?
No, I'll confirm on the MRI images. So I refer patient for MRI.
Any other differential you want to keep here?
It could represent non-ossifying fibroma. However, I will not expect it to be septated and expansile. So it could also represent aneurysmal bone cyst. However, this is most likely metaphyseal, not diaphyseal. But
do you know the age? I have given you the age of the patient. It is 13 years. Ewing is less likely as I can't see any aggressive features. This could represent osteomyelitis, and Langerhans histiocytosis as well will be in my differential. Okay, we'll see the MRI.
Dr. Dipti, time is up.
Okay, yeah. So here we will stop. You did good. In the second case especially, you did very good by picking up the finding. And I just give you you have done 3 cases, but overall you did very good. Here you had said all the buzzwords which I wanted to hear, but only thing is look about the history. Say if the patient is young, I would be thinking about osteofibrous dysplasia rather than adamantonoma. Adamantonoma is usually like in adult age group, 3rd to 5th decade. And osteofibrous dysplasia is the one which is benign, not the adamantonoma. Adamantonoma has to be en bloc resect because it presents with distant metastasis usually. So if you are saying an adamantonoma, say this patient needs follow-up and there are chances of metastasis, so you will refer to orthopedician, let them take the call. Okay, and adamantinomas are usually larger lesions rather than osteofibrous dysplasia. That is one point radiologically which you can differentiate, and second is age. That is the only 2 points which we can differentiate them from. Okay, apart from that, there is no other point where we can differentiate them. So if you are seeing a smaller lesion in young patient, you can say follow-up. If you are seeing an adult patient, then say that it is most likely an adamantonoma and they are in chance of metastasizing. So we will alert the orthopedic team, they will take it out or whatever. It is their call then afterwards. Okay? And then...
allow me to interrupt for a moment, Dr. Ritu.
Yes?
For 2B purposes, it is always better to say benign or aggressive rather than saying benign or malignant. After saying aggressive, they specifically ask whether it's malignant or not. Then you can go into the details of it being malignant or not. So for instance, osteomyelitis will also be called aggressive lesion and not into benign or malignant etiology. So it is always better to say benign or aggressive to begin with. Yeah, thank you so much, Dr.
So where did I go? Nice. I have to go to my smaller screen. Just give me a second. I'm reaching my cases for.
Please. Sure.
I'll just add one thing till that time. The adamantonoma, the MRI is recommended when you are looking for adamantonoma because there most of the time is you have to look for the foci, multiple foci can be there. So when you're giving a differential diagnosis, the reason why you'll be asking for MRI is when you're considering differential diagnosis as adamantonoma, I would like to look the foci in rest of the bone.
Okay. For metastasis, right?
Yeah. skip lesions kind.
Yeah. Okay. Thank you. Here, this case, here, my screen is visible, I hope.
Yeah.
Yes, it is visible.
Yeah.
I don't know what is the zoom bar is coming on the top. How to make it down? I am not understanding.
It's okay. We'll figure it out in the next session, Dr. Yuti. So
Yeah,
today,
good.
what we'll do is
Uh,
complete the cases. You can see
I'll
your
leave it.
cases.
So you can see this case, right?
You can
The
right click
hangman's
on it and open image in a new tab. You can right click on this particular image and then open image in new tab. Not like that, madam. No, not like that. You did it correctly for the first time. Right click it, right click on the image and open image in new tab, and you can go to the new tab, and this is much better than what we received.
Okay. My screen is not getting bigger. That is the whole.
That's okay. We can see your Zoom screen.
So here you can see the hangman fracture is visible. You picked up rightly, but only thing is, if you are seeing an unstable fracture, say about a CT, even if you are very sure, because there might be some fracture which is impinging over the cord. And secondly, in this case, there was a foramen transversarium fracture, which is very difficult to pick up on MRI. Okay, so in cervical spine or any spine per se, even if you are seeing a fracture, say that you would go for a CT, that we always do in a routine practice. You did not ask for a CT, so I did not give you one. But for this case, you should have asked for a CT. Okay. Rest you had picked up in MRI. You did not say anything in the MRI about the interspinous like edema. So if you are seeing this much big separation of both the spinous process, you would definitely see an edema. I would show you the CT because just to show you that.
Dr. Dipti, did candidate 1 speak about immobilization of the spine?
No, she did not
She has
talk
to.
about that.
If the spine is not immobilized, you have to urgently do it to prevent further injuries, as well as look at the vessels for any flow void or any injury.
So here you did not ask for a CT, so I did not show you. Can you see there is a right-sided foramen transversarium fracture, as well as this side of the posterior facet is impinging inside the canal, so it becomes an unstable. Had it been only a fracture of bilateral pedicles or lamina, then you would have not called it unstable. Just it would have been gone by immobilization only, and there was no foramen transfer. And after foramen transversarium fracture only, this patient needed an MRI to just look for the flow void. That was the only reason MRI was done for this case. Okay. And because this element is being impinged upon, you can always say that yes, if patient is going into surgery, if they want to look for ligamentous insertion, then you will go for an MRI, because these patients won't wait. These are unstable fracture. They will immediately go to OT. MRI will take time to be done, right?
Okay.
Rest you did fine. You picked up the findings. You said all the buzzwords. Immobilize the spine was one word Dr. Sandeep has added. That was good. You should have added that. And I would score you a 6 in this, except for the thing where you did not say about a CT. That's the only thing you should have asked for.
Thank you so much, Dr. Dipti.
Yeah, just a second. I'll show you the next case as well. There is one more case.
Okay.
I think it's the abdomen case, madam.
Yes.
Yeah.
So this one, you picked up all the findings. You said all the things. One only thing I wanted to add, you should give differential. You are not giving differentials. You are just giving one diagnosis. Here you told about lymphoproliferative disorder. That is very right. And it was a Burkitt's lymphoma. Okay. And first thing, I wanted you to scroll down because I wanted you to pick up this. And then second time you told me that it is a uterine. Although I asked you to scroll till the bottom. Right? So keep that in mind, that it is a male or a female before saying that, because that will cost you, fine? And this is the thing, and you picked up the pulmonary embolism, that is good, and there was a thrombus here. And the other differential you can also say is a Kaposi sarcoma. Okay? Because in immunocompromised, Kaposi sarcoma is more common than lymphoma. But this was a Burkitt's lymphoma, though you were right in calling it as a lymphoproliferative disorder. That was good. There was one more thing I wanted to tell you in this. Bone you told after asking. Yeah, fine. Rest you did fine in this case. Only ask CT if a spinal injury is seen, immobilize the patient if already not done, and in a bone lesion, aggressive or a benign, like non-aggressive. That is the buzzword you have to speak.
Okay.
I just checked the chat. So you can start with the second candidate. I'll
Sure.
reply on the chat.
Yeah, thank you so much. Thank
Thank
you
you
so
so
much,
much.
Thank you so
Dr. Deepti.
much.
Candidate 1, please stay with us for a moment. Yeah. So candidate 1, you did very well. The plus points are that you're confident, you're fast with the cases, and the most important thing is that you complete cases, something which most of the other candidates are not doing. So without even prompting, you're completing the cases, you're doing the management part and then stopping. So that is something very good, brilliant, and well tackled. All the cases well tackled. The negative points that you have to work upon is number 1, look at the entire scan. What I did during my exam, whenever they showed me a CT or an MRI, any cross-sectional study, before scrolling, I told them that I will scroll through the entire case and then speak about my findings. So you can go through the entire case within 4 to 5 seconds, a quick scroll, and then come back again on the superior aspect and then slowly scroll once again. So that actually helps you to get a basic idea of what the case is, whether the case is a male or a female, and what all findings are there. So you can look at you have to look at the entire scan first. The second point is do not panic. You're doing well, you're speaking well, you know your stuff, your knowledge is good. Do not panic. Work your way through. Your approach is most important. Even if you're not getting a proper diagnosis, like in this abdomen case, you found everything, you spoke about all the findings. Even if you don't know the final diagnosis, that is good enough, you'll pass because you've seen everything, every finding has been picked up. And that is it. So well done. I will give you a 6.5 out of 8 overall. So well done.
Thank you.
We look forward to have you again as a candidate in our future sessions. Till then, candidate 2, are you ready? Please say yes, sir, if you are ready.
Yes, sir.
Yes, and Dr. Swati, are you there with us?
Yeah, can I share my screen now?
Please give me a moment. I have to reclaim the host, and then I will make you the host, and then you can share your screen. Just please give me a moment. I think you are the host now.
Okay.
You can share your screen, madam, and you can also give the control to candidate 2 if you need.
Yeah.
And I'll start the timer as soon as you want me to.
Yeah, I think we can start the timer.
Started.
Candidate 2.
Yes.
This is an ultrasound of a female who has presented with some husky voice. You can start.
Yes. I'm provided with the ultrasound images of the thyroid scan. Here I'm able to see a heterogeneous lesion with a peripheral halo in the region of the right lobe of thyroid. Posterior to that, I'm able to see a hypoechoic lesion along the right side of thyroid. I would like to see the other images also.
Yeah, this is a longitudinal image.
In the longitudinal image, I'm able to see a heterogeneous, predominantly heteroechoic lesion with multiple cystic areas within. Can I see the other image?
Yeah, this is the transverse image of the left lobe. That was only finding in the right lobe.
To summarize, I'm able to see a heterogeneous, predominantly heteroechoic nodule in the right lobe of thyroid with the associated hypoechoic nodule just posterior to that. With the hypoechoic lesion just posterior to that, I'm considering a thyroid nodule with a adjacent lymph node in relation to that. I would like to inform the findings to the clinician. I'll try to do a FNAC to the lesion.
What is your primary impression by seeing this particular section, longitudinal section?
In this, the lesion looks heterogeneous. I would do a Doppler to look for the color flow. I'm not able to see any punctate calcification within the lesion.
Mm-hmm.
There are multiple cystic areas within the lesion. So it looks like a suspicious lesion. So I would like to do a FNAC for that lesion.
Can you tell me what are the findings for the benign and the malignant lesion in the thyroid?
Benign lesion can be either a spongiform lesion or a hyperechoic lesion with a peripheral halo without any it is usually oval shaped, wider than taller lesion. Whereas a malignant lesion usually will have increased vascularity with punctate foci of calcification within predominantly hypoechoic lesion.
Yes. So, what these findings now with those findings that you enumerated, can you tell me whether this is benign or malignant?
This lesion is predominantly hyperechoic without any foci of calcification, and it is wider than taller. So it could be a benign lesion, probably.
Okay. Nuclear study was done for this patient.
In a nuclear scan, I'm seeing the nuclear scan anterior view. There is a increased uptake on the right side. So it is having increased uptake suggestive of a hot nodule.
Anything else you would like to add? About the background thyroid?
The background thyroid itself shows increased uptake with a focal increased uptake in the right lobe. So it's a hot nodule with diffusely enlarged right lobe.
And anything on the comment on the left lobe?
In the left lobe, there is mild increased uptake in the left lobe. Other than that, I'm not able to see any focal increased. There is diffuse increased uptake without any focal uptake.
Okay. So can you summarize?
To summarize, heterogeneous, diffusely enlarged right lobe of thyroid with a heterogeneous nodule in the right lobe. In the nuclear medicine scan, there is a diffuse increase in the uptake in the both lobes of thyroid. So my possibility will be a diffuse thyroiditis.
Okay.
I will inform my findings to the reference.
Any other differential?
Toxic nodule.
The thyroid functions where your patient was nearly new thyroid in this case.
Euthyroid patient. Then I'll do a FNAC for this patient. I'll convey my finding to the referring clinician and arrange for an FNAC.
Okay. Next case. This patient is a 25-year-old who had presented with some numbness and weakness since 2 weeks. Do you want control?
Yes.
You have to ask for, I think.
Can you provide me with the control now?
No, I mean to say, is there in...
Dr. Swati, you can give them the control. In the bottom zoom bar, you will have an option of giving the control.
But to any specific name I have to give or share clipboard I have to do?
Not the clipboard, just...
Auto accept all request?
Not auto accept all requests. Just give me a moment. I will tell you. It shares... Yeah, once you share screen, or what we can do is...
I will scroll for you, not an issue.
No, candidate 2 can ask the host for the control. So then Dr. Swati will get the option of giving you the control. Are you able to do that?
1 minute. No, sir, I'm not.
Okay.
That's fine. I think I'll scroll for you. Let us not waste time.
That's better for today.
You can go through this images I've provided with SASH T2.
Ma'am, actually, I'm not able to see your screen.
Not able to see the screen.
Yeah.
I actually can. What you need to do is, I think you have to
Yes.
share your screen again, Dr. Swati.
Okay.
Is everyone else able to see her screen?
Yes, even it is visible to me as well.
Yeah, it was me as well. So we'll try it again.
Yes. I'm able to see it now.
That's good.
I'm
Yeah.
provided with the sagittal T2 weighted MR images. I'm able to see a T2 weighted hyperintense lesion causing expansion of the spinal cord involving the mid dorsal levels. It appears hyperintense on T2. I can also see few T2 weighted hyperintensity involving the spinal cord at the just distal to the above mentioned lesion. Can I see the next images? T1 images.
Which one you would like to see?
T1. The lesion appears hypointense on T1 weighted images.
Provided with contrast.
In post contrast T1 weighted images, the lesion shows peripheral areas of enhancement with central non-enhancing areas within. There is no evidence of any peri-lesional cyst or a T2 weighted hypointense rim noted.
Any other sequence would you like to see? Hello?
Yes. No, ma'am. Axial images, ma'am. T2. The lesion is causing expansion of the spinal cord. T1 weighted contrast. To summarize, there is an intramedullary lesion noted involving the dorsal spinal cord appearing hyperintense on T2 weighted images, hypointense on T1 weighted images with heterogeneous peripheral post-contrast enhancement. My first possibility will be an intramedullary neoplasm, possibly astrocytoma with associated cord edema involving the distal aspect of the cord. I will inform my findings to the referring clinician and I'll discuss the case in the neurology MDT for further assessment and management.
Any other differential diagnosis would you like to give?
If there are T2 weighted hypointense rim, ependymoma can be a possibility. Or if the lesion is in the lower end of the cord, the possibility of myxopapillary ependymoma can be considered.
Okay. This is a case of a 17-year-old patient who had acute leg ischemia on the background of intermittent claudication.
Coronal MR. Can I start? Coronal MR angiogram images of both the legs. I am able to see short segment occlusion of the left popliteal artery up to the level of the tibiofemoral trunk. On the left side, the right side, the right popliteal artery, the tibiofemoral trunk, anterior tibial, and all the vessels appears normal. I would like to look for the CT or MR images of the patient because the patient is a sports person. I am suspecting any popliteal artery entrapment syndrome in the because of hypertrophy of the muscles of the medial head of gastrocnemius.
What do you think? What is causing filling of rest of the left lower calf vessels?
There is a large collateral vessel seen arising from the superficial femoral artery.
Okay. Here is your actual T2 for that.
I'm able to see an accessory medial slip of the gastrocnemius muscle, which is compressing the popliteal artery and causing thrombosis of the same. So this is a case of popliteal artery entrapment syndrome. For this patient, most of the time there can be bilateral involvement. So I will also do a Doppler of the other limb to check for any Doppler of the other limb in flexion extension to check for any involvement of the opposite side also. I will inform my findings to the referring clinician and arrange for a and send the patient to a vascular surgeon for the release of the slip and for a revascularization of the affected limb.
This patient had been operated previously and now is being evaluated because of some recent complaints. For the routine follow-up, the patient had come up for that.
Axial, I am provided with the axial non-contrast CT images of the brain in the cerebral window. I can see multiple calcified subependymal nodules in this patient. I can also see the post-operative changes with the craniectomy and post-operative gliosis changes in the right frontal lobe. I can see a ventriculoperitoneal shunt which is seen extending along the left right parietal lobe into the lateral ventricle.
Mm-hmm. So what do you think about it?
To summarize, there are multiple calcified subependymal nodules. So I would consider a possibility for tuberous sclerosis. Because the patient has been previously operated, the patient could have had a subependymal giant cell astrocytoma for which the patient has been operated previously.
Okay. Which all other organs would you assess in this patient?
For this patient, I will look for the lung because these patients can develop lymphangioliomyomatosis with multiple thin-walled cysts in the lungs, and along with it they can also have angiomyolipomas in both the kidneys. Can I describe, ma'am?
Yeah.
These are axial non-contrast CT of the abdomen. I am able to see multiple fat-containing lesions scattered in both the kidneys. Few of them are the size of few of them are more than 4 centimeters. I am able to see fluid within the peritoneal cavity with the ventriculoperitoneal shunt.
Mm-hmm. Anything else you're noting?
There is a perinephric high density fluid around the left kidney. I would like to do contrast.
Yeah, please.
The multiple can you please scroll it little?
Sure.
There are multiple tortuous vessels noted extending into the angiomyolipoma in the left lower lobe. So I would like to inform these findings to the referring clinician because any angiomyolipoma more than 4 centimeter has to be embolized in order to prevent the hemorrhage, as this patient is having already a hemorrhage in the left side.
Okay. And which all other organs you had asked me for? One was chest, yeah.
One
Chest.
left.
Axial CT of the chest in the lung window, I am able to see multiple thin-walled cysts diffusely scattered in the right lung as well as in the left lung. There is mild pleural effusion noted on the left side.
Mm-hmm. Yes.
So these are the findings of lymphangioliomyomatosis, which is the involvement of the tuberous sclerosis in the lung.
Mm-hmm.
Other than that, there can be rhabdomyosarcomas in the rhabdomyoma in the heart, cardiac rhabdomyomas.
Mm-hmm. And do you expect anything in the skeletal system?
Skeletal cyst. I'm not sure about that one.
Okay. Do you expect rhabdomyomas at this age?
They are usually seen in kids,
Okay. Yeah.
children.
Yeah, time is up, Dr. Swati, so I think we will wrap up the cases.
Yeah. So candidate 2, you have presented very well. The things always remember that when you should know where to stop when once you have described your findings. So then that gives a clue to the examiner also, to kind of you have noted your findings and we can switch to the next listing. So you have used your time very well. In this case, you were bang on. You have described everything properly. The rhabdomyomas, yes, they are seen only in the kids. Angiomyolipomas, you have described everything very well. Even the brain findings were picked up very well. Because expect this kind of cases where there are mixed findings and you are expected to pick many of them. This patient also you had picked up all the findings. Not a short segment, it's quite a long segment population. And this was not a slip actually, this was the entire muscle is more, I would say more laterally and the popliteal artery is medially. The slip would be something different. And as if you would always note the history, I had told that the patient has presented with acute symptoms. So, you have to be, that urgent word should come down in your thing that I would, because it's a critical ischemia kind of thing. So it needs an urgent attention.
Yes.
Then this case, yes, you are right, bang on, eccentric, not like you can see some exophytic component kind of thing, and all the differential diagnosis and the findings were right. Then in this case, actually the reason for showing you this case was for this, in exams you might probably be shown directly this nuclear medicine images. The point was to make you understand that when you see the both lobes of nodules along with no suppression in the lobes of thyroid and benign nature on ultrasound, you are looking at a multinodular goiter. So if this was a diffuse goiter like that of a Graves' disease, there would have been entire both lobes which would have bulged out. And if it was just a solitary hot this thing adenoma kind of thing, if that was a toxic adenoma, the other normal gland parenchyma would have been suppressed, which is not suppressed in this case, and that's why you are looking at a multinodular goiter. So these are 3-4 conditions in thyroid which can be shown up in exams. So one amongst them is this, which I have shown you. And when it is a toxic goiter kind of, even the submandibular gland uptake might not be seen, which is seen in this case. So that was the reason for showing this case. So you had picked up all the findings very well. You have well done and almost utilized your time properly. Dr. Sandeep, yeah.
Thank you so much, Dr. Swati. Candidate 2, please stay with us for a while. Thank you so much. Very interesting cases, Dr. Swati. We would like to have you again as an examiner in our future sessions. Thank you. Candidate 2, very well done. I would give you a 6.5 or a 7 out of 8. So very well tackled cases. Your plus points for today is that you do not panic. You're confident, you're fast, you do not panic. So this is a plus point. When you were not able to see the screen, you quickly said that you were not able to see the screen. And when you wanted the examiner to scroll the cases slowly, you did tell that too. So this is how other candidates should do. There is no need to panic. You will have some glitches, few lags, few problems, connectivity issues will be there. So you have to vocalize, you have to tell the examiner that you're facing problems. So that actually helps you. And one other good thing is that you complete the cases. Same what candidate 1 also did. You completed the management without being prompted into it. So this is something you have to do. Because some of the examiners might not even say a word. They'll just keep numb and they'll just show you the cases and they won't tell you anything. So you have to complete the cases on your own. So well done. Your negative points is you need to know where to stop. Same thing that Dr. Swati said. You have to make sure that you do not have abrupt pauses in the middle. For example, if you have a habit, this is not for you, this is for rest of the candidates and in general, This is not something you did, but
Yes.
if a candidate is having a habit of having a lot of pauses, so what happens if you stop, the examiner thinks that the candidate, he or she has completed the case, and they start speaking.
Yes.
And then you start speaking again, and they'll stop. With this, what
Yes.
happens if you have completed the case, if a certain candidate has completed everything, and after that what happens, the examiner is confused whether you're actually pausing or you have completed the case. So even if you're not able to find anything, just keep speaking, keep vocalizing, keep telling that whatever normal findings are there. And
Yes.
now this is another negative point for you is you all have a habit of asking for the next image, other image. This is something I noticed. You have to say which particular image. Like in Radiopedia, I understand that we are able to see the rest of the scan on the side of
Yes.
what you've shown, but in the exam that will not be the case. They might just show you the radiograph, and you have to tell what specific image you want, what specific sequence. If you want a CT scan in coronal section, you have to ask in the coronal section. Contrast or
Yes.
non-contrast. Be very specific about it. So overall, well done. Well done.
Yes.
And thank you so much, candidate 2. And today's
Thank you.
learning points which I want to provide to the candidates is, the first one is listen to the examiner. I saw that in few of the questions, candidate 1 was actually not listening to the examiner and was speaking over the examiner. Most of these examiners will try to help you and guide you towards the correct diagnosis. So if they are speaking, it's better that we stop and listen to them, because sometimes it will be a hint. That is point number 1. The second one is same thing what I spoke a bit earlier. Tell the examiner in any cross-sectional study, if they have given you to scroll, you can start scrolling. That saves you time. You can start scrolling, and while scrolling you can tell them that I will quickly scroll through the entire scan and then come back to my findings. So quickly, within 4 to 5 seconds, quickly scroll from up to down, and then you're done. You can come back to the superior aspect and then start scrolling again. So the examiner knows that you're getting a basic idea. Some of the examiners will even tell you to do so. They'll tell you that you just, before speaking, just go through the entire case and then you start speaking. So this is point number 2. The third point, which is more important, none of the candidates today did. Before the case, you did say that you have been presented with so and so image, but it is always better to add the history along with it. This is what I did. This is what most of the successful candidates do. So for example, you have to say, I have been presented with the coronal angiography MRI images of a patient who presented with acute ischemia, acute leg ischemia and intermittent claudication. So what that does is that actually gives the examiner a choice. If suppose you have heard the history wrong and you repeated the history wrong, the examiner will correct you. That is one thing. And the second part of it is you know the history. So you have repeated the history, that means you have the history in your subconsciousness. So that is something you should do. Along with what image it is, speak and repeat the history again, just to stress on it. So these are the points to take for today. Any other thing, Dr. Dipti and Dr. Swati, you want to add?
Only one thing I would like to add for all the candidates, that when you're scrolling this cross-sectional images, if you're not seeing any finding, if you've scrolled entire this thing, rather than getting panicked or something, you can always vocalize that I'm scanning through the images, I'm seeing liver, I'm not seeing any finding, I'm seeing spleen, I'm not seeing any findings. So, that will help you. And sometimes the examiners might give you hint, okay, go towards the lower sections and see and tell me what you're seeing. So that will save your time also, and that is how that time economy will be taken care of.
Exactly, that's a very good point. So if you've not found anything in the scan, you can come back to the top and start speaking about the negative findings. For example, I'm seeing the liver, I do not see any focal or diffuse lesions. Now I'm looking at the gallbladder, there are no gallstones, no other lesion, no pericholecystic edema. So you can keep vocalizing and start speaking, and the examiner will understand that you have not picked up the finding, and they will try to prompt you. So that is a very important point, Dr. Swati. Thank you so much, and we'll meet again on Tuesday.
Yeah,
so
we'll
another
meet
just a request once again, candidates as well as examiners, please join at least 5 minutes before the before the session begins.
Yeah, sure.
So, thank you. Good night, everyone. Any other questions you can post in the Telegram group.
Thanks.